Coming up today, a young mom thought a lump was just part of postpartum life. Instead, it was breast cancer. Good morning, I'm Jessica Lovell and welcome to the Morning Medical Update. Kat Robertson was just 28 years old and in the middle of some pretty big moments in life when a new diagnosis changed everything. 28-year-old Kat Robertson was in the midst of some big milestones. Her and her husband had just moved into a new home. Their daughter was just 4 months old when one night while lying in bed, Kat felt something.
I was like, I don't know, this just feels weird. Should I say something? But it's 9 o'clock at night. I can't do anything about it. So I just rolled over and went to sleep.
She had a mammogram the next day, followed by an ultrasound a week later.
The radiologist walked in and he was like, yeah, so we found a couple of spots and your lymph nodes are enlarged. And I was like, oh my goodness. Okay, so of course I just start sobbing, and then he is like trying to be as nice as he can, but I think truly he knew, I think when he saw the pictures that he knew what he was looking at.
Her doctor called her with the official diagnosis.
Following Tuesday, which was December 3rd, was when they called me and told me that I was positive for invasive ductal carcinoma.
It was breast cancer. Her team at the University of Kansas Cancer Center started Kat on a chemotherapy regimen, followed by immunotherapy injections. It was a lot for Kat. She craved normalcy, especially as a new mom. Another part of her treatment, Kat wanted to try cold capping, a treatment that helps reduce hair loss caused by chemotherapy. The sessions require you to wear a specialized cap at an extremely low temperature before, during, and after chemo treatment.
There would be days that she would play with my hair when I was holding her, and I was like, what if I didn't have hair? I'm just very thankful that we chose to do that. And truly, I think that that's what saved so much of my confidence and my strength going through everything, because I could look at myself in the mirror and still mostly look like myself.
Kat went on to have a double mastectomy followed by a reconstruction surgery. She's allowed very little to slow her down. She'll finish immunotherapy treatments over the next couple of months and remain on an estrogen blocker for 5 years. That will determine when and if Kat and her husband can expand their family. In the meantime, she's just truly grateful for what's in front of her.
I think it's definitely engraved in my soul that that is what we focus on, regardless of what's going on in the world. What are the positive things that we can pull from this, and what is the good that we can do from it?
And Kat is here in studio with us this morning, joined by breast surgical oncologist Dr. Jamie Wagner right here next to me. And we also have plastic surgeon Dr. Rebecca Farmer joining us. So glad to have everyone here with us at the table.
Thank you. It's great to be here.
Yes. Kat, just how are you feeling today?
Good, really good. I'm just grateful to be here. It's a little cold outside, but otherwise there's really nothing to complain about today for sure.
Well, that's such a great attitude to have, and we're just glad to have you here sharing your story with us and just knowing that you're doing well. So tell us, so you first feel this lump that late evening in bed. What made you decide to really take it seriously and get it checked out the next day?
Yeah, I think I had a gut feeling, not that it was cancer, but that it shouldn't be there. And we were in between houses at the time and living in my mom's basement, and I was making coffee the next morning and I was just kind of messing with it, and she's like, what are you doing? And so I had her feel it, and she's like, you need to call. So I was like, oh, okay, I will.
Well, and again, postpartum, you got a lot of things going on with your body at that time, and a lot of, like we said, milestones going on. So it would have been easy to just kind of go, oh, I got a new house I got to move into, I got a new baby, I got a million things going on.
Yeah.
Maybe we hold off on that for now. So glad she didn't do that, Dr. Wagner, Dr. Farmer. She did the right thing. How common is it, Dr. Wagner, to see a breast cancer diagnosis in your 20s, late 20s?
Yeah, it's not, right? It's very rare. Less than 1% of our breast cancer diagnoses are in women in their 20s. But the interesting thing is we are seeing an increase in incidence over the last couple of years by as much as 2% annually. So there's a lot of different things that are changing in our environment that we need to take into consideration. We know that women are giving birth at much later ages because just our world has changed, right? A lot of careers, and women are putting off having children until after, and that is impacting by having them later in life, not having as many children is what we used to as well. And as well as just our lifestyle, right? Everything has become very easy and electronic, right? And so, like, easy access is what I'm meaning. So we don't move. And so what are we seeing coupling with that? Lots of changes with diets, lack of exercise, higher weight, right? So there's a correlation with obesity and breast cancer. So when we take all of those environmental factors together, we can kind of reason, I guess, out why we might be seeing that increase.
Which makes this conversation so important because we just don't think about it in 20s and 30s. Dr. Farber, how do we make sure that women are aware of these factors and that they're asking questions and doing what Kat did? You feel something, go in. See something, say something kind of attitude.
Yeah, I think it's just critically important for people to be really attuned to their own bodies. I don't know that we do a good job sometimes of taking stock of how our body feels that day or over time. And so it's really important, I think, as Kat did, the totally right thing. When you feel something different, say something, come to us, insist, that basically it gets looked at. Patients, really have to self-advocate and definitely, let us know when something just really doesn't feel right, because our job is to listen to that and take that into account and make sure that it gets taken care of. And I'm so glad that she did.
So Dr. Wagner, that brings up the obvious question. Mammograms not recommended till you're in your 40s. So when should women start doing self-breast exams? Where do those fit into the picture?
Yeah, I mean, we really should be introducing, once women are starting to go through puberty and develop, introduce it then, right? Not as a scary thing, because unfortunately, when you look at years past, fortunately several decades ago, we had the shower cards. We were told that's at the time that you do it every month, you do it this way. But the problem is that instilled a lot of fear that I'm not doing it right, it's the wrong time of month. We have gone so far away from that. It is, as Dr. Farmer was just eloquently stating, know your own body, and when something changes, we need to be getting it checked out.
So tell us a little bit more about the self exams. Do them, but we don't want to be missing mammograms. Mammograms are essential. They do not take the place of mammograms.
Yes, every woman wished that would be true, but unfortunately it's not. There are very early stage breast cancer is what mammogram allows us to identify. We don't do it in women before the age of 40 because of several reasons. One, it's the incidence. Although that I had said it's on the rise, it's still less than currently about 1% of the population, but you have to couple that with what the breast tissue actually looks like in our 20s and 30s, because we have very dense breast tissue, which lowers the sensitivity of mammography. The best way that I can describe it is cancer shows up as white on a mammogram, and dense breast tissue is white. So it's kind of like finding a cotton ball in snow, right? And so that is what makes it challenging. So when we put all of that together from a statistical standpoint, we don't have enough added benefit for patients. But in that younger population, that is absolutely where just being comfortable with your own body, knowing what is different, and then being your own advocate.
All right, so Kat gets diagnosed at 28. Explain the treatment path for a patient like Kat.
So first and foremost is understanding what type of breast cancer they have. We know that is truly the foundation on which we build all of breast cancer treatment now. It is very tailored, and it really brings all the disciplines together, from the radiologist and pathologist, from your diagnostic team that segues right into the treatment team with the medical oncologist, surgical oncologist, radiation oncologist, as well as your reconstructive plastic surgeon. So we need to be bringing all that together, and timing matters. So what the type of breast cancer is, as I refer to it as the personality type, I think that's the best way for patients to understand that breast cancer is a family with a lot of personality types. So what is this personality type? And then according to that, we tailor therapy. it is not just the order, getting the right treatment first, whether it's the medicine or it's the surgery, but it's also the targeted therapies that have expanded so much and made such a tremendous difference in patients' outcomes.
Dr. Farber, when a patient like Kat needs reconstruction after cancer, and you know this going into it, what factors guide those decisions? What kind of conversations are you having up front?
Yeah, so we have very kind of long initial visits to really go over all of the various types of reconstructive options, of which there are kind of two main types: implant-based breast reconstruction or tissue-based breast reconstruction. And we kind of talk about all of those options, but I think much like breast cancer is a family with lots of personalities, so is reconstructive surgery. And no two solutions are going to be the same for each individual. And so really what we take into account more than anything, the first thing I ask people is, what's your goal? Why are you pursuing reconstruction? What are you hoping to get out of it? What is kind of the overarching goal of why we want to do this? And that helps me get a sense of what's in patients' heads about, you know, I'm looking to look normal in clothing so that people can't tell that I had surgery, or, you know, my breasts are a really important part of my self-image, and so I'd like to maintain that appearance as much as possible. I want to have as few stages as I can, or I really don't want an implant. That sort of scares me. And so we kind of talk about all of those things and try to tailor that particular reconstructive surgery to the person.
So lots of options is what you're saying.
Lots of options.
Kat, you get this diagnosis very soon after your baby is born. Like we talked about, a lot of great milestones going on in your life at the time. How were you handling this?
It was hard. It was really hard, but I think that just the way that my personality is it's so incredibly type A. It's like nauseating sometimes, and I really kind of looked at it of like, okay, these are my tasks. These are the things that I need to complete. And in doing that, I still have a family to run. I still have a house to raise. We moved into our new house 4 days after I felt my lump for the first time. And so I still had life to live. And I think that that's what was interesting as like a nurse going through my own thing, is now like there's a life outside of the hospital walls, and I was experiencing that firsthand.
So how did being a nurse help you navigate this? Did it change the way you approached it?
I would say kind of yes and no. It was like I knew a little bit too much to be dangerous, because I like understood things. So I would read before I got my initial imaging at an outside facility, and then Dr. Wagner wanted to repeat everything, and so we did, but then they found 3 spots instead of 2 initially, so I was spiraling on my couch as my toddler's like screaming at me for a snack, and I'm trying to process in my mind like, oh my gosh, now I have 3 spots to worry about. But then once I could meet with the team, then they explained that it's because of the way that the machines at KU look at it as like a full picture versus just one side and the other, whatever. So that was difficult, I would say, just knowing a lot enough medical, and then, but I think it was also really cool to be able to see the nurses that I interacted with so much during my treatment. They are seriously God's angels from earth, and just are like such incredible humans and want the best for you and for you to be comfortable. And so that inspired me a lot in my practice as well with my patients.
A big part of your story, of course, is being a new mom. And we know being a new mom, you said your appearance was a big part of that, and having your hair was a big part of that. Tell us about cold capping and your decision to do that.
Yeah, so at first I was a little hesitant. I thought it was just kind of a rite of passage of when you get cancer, you just lose your hair and you learn to live with it. And then I have fortunately and unfortunately, some friends that walked this path before me, and they were like, you have got to do it. It's expensive and it's not covered by insurance, so that is definitely a barrier that a lot of people have, but luckily we were able to make it work. And I told my husband, I was like, you know how I am, are you gonna be able to do this? Like, because I can't do this by myself. And I'm so thankful that we did it. I think it allowed me to, I still worked all the way through all of my chemo, and until I was ready to tell my team, no one knew what I was going through on my days off. I could go to the grocery store, no one there knew that I had cancer. I could just like kind of fake it till I made it. And I think too with our daughter, she was I guess 14 months at the time of when I started treatment, and so she wasn't old enough to know like what hair is necessarily, but she would be able to look at me and be like, you look like something's off, kind of thing. So it was just a good way to keep my confidence and my strength, I think.
Dr. Wagner, how important is it to have an option like cold capping for patients who that is a really important part of them? I interviewed a patient the other day who was in a wig, and she took her wig off and she's like, I don't even like wearing a wig. I love having my bald head. And then you have some people who have a baby and they want their baby to be able to twirl their hair and tug on mom's hair, because that's an important part of their journey. And to know that there's options out there for patients, it's so important, and I love that.
Yes. I mean, as in every area of breast cancer, I think what Dr. Farmer was just talking about from reconstruction, we continue to want to expand, because the entire reason we're doing all of this treatment is to keep people living, right? And I always tell patients, don't stop living in the middle of it. Let's find out what are the priorities, and we may not be able to meet every single thing when you want it, but as much as we can, we want to, and that's where exploring new opportunities like cold capping, which we are now able to offer. It's also an important partnership with your medical oncologist, to be very honest, and I know that Kat had that with hers, but not all chemotherapy regimens are really conducive to success in the cold capping as Kat had. I will say, as she came in for her mid-treatment, I actually did a double take. I'm like, I know you're getting neoadjuvant chemotherapy. Like, for all things, I know that this is happening, but it was just great to see, and it helped her. Like, it lightened the burden maybe just a little bit to have that wholeness feeling still throughout this. Sometimes based on the chemotherapy regimen, the data just shows that the cold capping isn't going to work. It's not going to be as successful. And that's where I think also going into it with realistic expectations, which she also did, right? Is she understood that she still had some thinning, but for the most part, nobody would be the wiser. But she had realistic expectations going into that process.
Dr. Farmer, just add to this conversation just about having those realistic expectations when you're having those conversations with patients when it comes to things like cold capping or reconstruction.
Yeah, I think my breast surgery colleagues maybe get annoyed at me sometimes, because I sometimes paint like a very, not grim, but I think realistic picture of what a reconstructive process is like, because it's very much a process. There's no such thing as kind of a one and done reconstructive surgery, and it can require a lot of revisions and things to kind of get things looking and feeling the way that we want them to. And so, I try as much as possible just to really spend a lot of time being very realistic about, these are all the potential complications, these are the things we might see, but essentially we're your partner in it, and we're gonna stick with it until we get it the way that we want it to be. And sometimes, yes, you don't get what you want when you want it, but I think eventually we can kind of work that path together to get where we need to go.
Is it a matter of helping them prepare physically and emotionally?
It's really both. But I think the emotional component is really the biggest part. I've never personally experienced a breast cancer diagnosis, but I have met a lot of people who have, and I think that is just such a life-altering event. You can sort of never go back to the before. And I think that people have to spend some time mourning that old life and that old way, and kind of accepting this new life and this new way. And certainly a lot of things are different, and your body feels different and it looks different. And so I tell people it's fine. Like, there's going to be days where you need to cry. You're going to have a low day. You're going to have some up days. Some things are going to feel like wins. Some things are going to feel like losses. And I often refer people to psychological counseling as well, because I think that component of it, and part of the reason Kat did so amazingly well through this, is she kept such an amazing, positive, realistic attitude. And that, I think, spoke so much to her overall success in terms of her surgical outcome.
Kat, on that note, just as far as advice for other moms, new moms, possibly going through this, what was the hardest part of balancing treatment, the diagnosis, and motherhood? What advice would you have for other moms?
I think as far as treatment was hard, of course, but I think as far as motherhood goes, mom guilt is real, and it doesn't matter if you have cancer or you have to go to work or whatever the case may be. I think it's just a matter of giving yourself grace. And my husband always told me, like, we really leaned into our family, our support system, and being able to know that, like, even though it may not be us that's taking care of our daughter at this exact moment in time, she's getting all of the help and love that she needs. And I have to focus on myself and my recovery in order to be here for her in the long term. So.
Well, be sure to ask your questions. Use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. Dr. Wagner, what are the biggest red flags that young women should never ignore, even postpartum?
Yeah, absolutely. First and foremost, I think, obviously, Kat is a perfect example. She felt a new mass. Like, she didn't know what it was. It was different, and that's all that matters. And she followed up on that. If there is ever unusual skin redness, skin thickening, and people have a hard time understanding what that means, but like if your pores all of a sudden are dilated, and that's not normal. Any nipple changes, retraction, skin retraction, crusting of the nipple, sometimes even just some early pruritus or itching that is not being remedied by over-the-counter or even sometimes some prescription type of hydrocortisone creams, we probably should be checking those things out. The other couple things I'd put with that is we focus on the breast, and we need to not forget to put our hands in our armpits, because the breast tissue will go all the way out, sometimes very prominent out into the armpit area, the axilla, or we also might be able to feel a lymph node. And those are also things that we should really seek attention. In particular, I want to speak to the postpartum, if that's okay for just 1 second, because women who are nursing in particular need to be probably the biggest advocates of all if they have a new mass. It is very challenging. Your breast, when you're nursing, feels nothing like you've ever experienced in your life. And having nursed while taking care of breast cancer patients was an interesting experience for me, because if you have a clogged duct, I thought to myself, in my early, young, uneducated life, I might have been overly critical. Like, how did you possibly miss this? But once you have a clogged duct, it's like, oh, you just think everything's a clogged duct, right? And so if it is persistent, those types of things, clogged ducts resolve. But if there is something persistent, get it checked out. And just because you're nursing, because you've just had a child, doesn't mean you can't also have breast cancer. And don't let somebody say, you're not old enough. This doesn't happen because you've just had a baby. Those are just not truths.
And that's going to bring me to what we always talk about, which is screening, which is going to bring me to the Crucial Catch, because Kat, you were chosen to participate in the Crucial Catch. It's the annual NFL initiative for the prevention and early detection of 7 screenable cancers. What was this experience like for you?
It was so amazing. We've been Chiefs fans our whole lives, and so just being able, and I've been to the Crucial Catch game before, and I've written other people's names down on there, and I honestly remember initially being diagnosed, I was like, oh my gosh, someone's going to be writing my name on that letter now. And so initially that was like a little bit terrifying, and then by the time that the game came around, I was done with chemo, and I had reconstruction, and then I was still doing my immunotherapy treatments. So it was more of a celebration that day. And if anyone saw me on the field, I couldn't stop jumping up and down just because I was truly having so much fun and just celebrating like I guess like Dr. Farmer said, my life after cancer.
Well, as we mentioned, breast cancer is just one of the 7 screenable cancers that can be detected early. In addition to breast cancer, those are prostate, cervical, childhood, colon, lung, and skin. And we do want to remind you that scheduling a screening is quite easy. And the University of Kansas Health System is dedicated to providing resources to make scheduling and screening as simple as possible. Kat, just tell us what's your follow-up care like today?
Well, I rang the bell again
Yes.
a couple weeks ago. I finished my immunotherapy, so now I am just on my estrogen blocker for the next total, I guess I'm almost down to 4 years. I've almost been on it for a year, but I'll do that for a total of 5 years, and then follow up with my oncology team every 6 months. I see Dr. Wagner's team here, I think next week, and continue to follow up with Dr. Farmer as well of just how things are looking aesthetically more. So.
Well, we want to get to some questions from our viewers this morning. Jean wants to know, and I think you touched on it a little bit, Dr. Wagner, but does cold capping work for all types of chemo for cancers other than breast, like lung cancer?
Not necessarily.
Okay.
And that's where you really need to speak with your medical oncologist. What is the treatment regimen? We know that there are certain types of chemotherapy agents that it just does not have the same success.
Jeremy wants to know, is breast cancer always preceded by a lump in the breast?
Oh, that's
or
a great question.
Are there other things to look for when you're checking yourself?
Yes. No, it is not. Probably unfortunately, because then we could detect them and maybe much earlier, but the different skin nipple changes that I had referred to earlier, as far as redness, puckering, nipple inversion, crusting, those are also things that we want to look for. And this really highlights why screening is so incredibly important. We have the best successes when we can identify breast cancer early, and unfortunately, yes, we don't have it for the general population under the age of 40, but breast cancer screening should start at the age of 40, and we absolutely recommend it annually. Although there has been a lot of debate on how frequent we should be doing screening within the breast cancer community, we definitely advocate for annually. That's what allows us to identify breast cancer early, and that's where we have the best success.
Isla wants to know, Dr. Farmer, how soon after treatment can you have reconstruction surgery?
It's a little bit variable depending upon the treatment. So, for instance, in Kat's case, when she had her mastectomy, we actually started that reconstructive process at the same time. And so Dr. Wagner and I have a lot of days every month where we operate together, where we're basically doing combination mastectomy, oncologic surgery in combination with the initial steps of the reconstruction. Subsequent revisions, for instance, if we need to do something to kind of improve the appearance, or if we're doing a nipple reconstruction, for example, usually come a few months later after the initial surgery, just to give the body time to kind of recover and the swelling to go down, and really for us to have a good understanding of how things are looking and what we need to do. Sometimes the timeline can be a little bit different depending upon if patients need what we call adjuvant therapies, or therapies after their surgery. So say, for instance, if a patient needs more chemotherapy, or if they need radiation in particular, that can kind of extend our timeline in terms of how long we wait to do some reconstructive things, and that's usually on the order of about 3 to 6 months for some of the kind of other revisions that we do. But ultimately, I think we can really, in a lot of cases, get the process started right away, and then work through it over the over the intervening months later on. After essentially my job is to get out of the way, start the process, and then get out of the way, right? And we just want people to heal from that initial surgery, and then not have any problems with their reconstruction, so that they can get through the rest of their treatment. We can do the fun stuff later, and it's really critically important, but at the same time, we can't interfere with their oncologic treatment.
Dr. Farber, what's the big takeaway today? What do you want folks to know?
I think the big takeaway is just be a great self-advocate. If you notice something different, say something to anyone. You know, I'm a plastic surgeon, but if a patient came to me and said I felt a lump, like I'm more than happy to and willing and able to order a mammogram and get that process started. We want people to be aware of their bodies, advocate for themselves, and know that we're here to be your partners in this process, and that certainly the road is not smooth and it is not always going to look the way that we want it to, but our job is to sort of hold your hand through it and make sure that you get the outcome that you really want and that you deserve. So we're here for you to make it happen.
Kat, thank you so much for sharing your story. We're so glad you got to hear that bell ring again. What's the big takeaway? What do you want people to really hear from your story?
I think kind of what we've talked about, cancer can happen to anyone. I have no family history of this. I had all the negative risk factors. There was really no reason for me to think that this was going to happen to me, but it did. And I very luckily found it when I did, and started the process as quickly as I did. And I think just staying focused on what your end goal is, leaning on your people, and just staying as positive as you can through it all, and it's going to be okay in one way or another, whatever. That looks different for everyone, and I recognize that, and I'm very blessed that I came out on this side of things, because I know that doesn't happen for everyone. So
thank you for being with us today. Dr. Wagner, wrap us up.
I would say my takeaway is understanding that this is a individual journey for every patient. And I think that that's what was definitely highlighted with Kat, as well as all the details that Dr. Farmer gave today. With social media, everybody is out there and they're like, but so-and-so did this, but so-and-so had this. They're right, but we're in the era of, you know, right-sizing treatment for every individual patient. We're gloriously made as women unique, each of us. And that is how we have to develop cancer treatment. So no two cancer treatments are going to be the same, and so pick your own journey.
Thank you for your insight. Yeah. Doctors, thank you so much. Thank you to all of our guests and to all of our viewers for being with us today. Coming up Monday, Reggie Hong was pregnant when we learned that she had breast cancer. One doctor suggested that she terminate the pregnancy. Then she came to the University of Kansas Health System. She is now advocating for second opinions.
Subscribe to our morning medical update and open mics with Dr. Stites podcast. Now everywhere podcasts are available.